Good morning and welcome. Thank you for joining our presentation this morning. Today's presenter is Dr. Cornel Engelbrecht. He is a very important part of our team. He is a specialist physician practicing here at Mediclinic Midstream. He does mostly all the general work of a physician, also works in our ICU. And today he's talking about fatigue.
Thank you very much, Leanne. Yeah, thank you very much. I decided on this topic because lately you get confronted by this problem in quite a regular basis. So I thought we'll just have an overview of fatigue and how to approach fatigue. So fatigue is a very non-specific symptom with a very broad etiology. It can be acute or chronic medical conditions. It can be psychological, can be due to medication, toxicity, and even substance abuse. And it's actually very important to distinguish it between excessive daytime sleepiness and then also your muscle weakness or myopathies. So fatigue basically encompasses a couple of things. First of all, you have difficulty or inability to initiate activity. And patients usually have a subjective sense of weakness. You also have reduced capacity to maintain activity. They are easily fatigable. And then they have difficulty in concentrating, memory and emotional stability, what we call mental fatigue. So it is very common, about 21 to 33% of primary care visits in the US, patients will present with fatigue. And it's actually more common in females. And the impact of that is that 38% of US youth workers report fatigue, and it has quite a big cost implication. So if we look at fatigue, you basically can have three types. First of all, you have acute fatigue, which is usually less than a month. That is where you have an infection or a stressor, and usually easy identifiable, and the symptoms clear up. And then you get subacute fatigue, and this is where it ranges from 1 to 6 months, and then chronic fatigue. And this is more than 6 months. And it's important to also distinguish between idiopathic causes and then also your chronic fatigue syndrome. So the key features, as we said, it's difficulty initiating activity. You've got reduced capacity to maintain your activity and you're easily fatigable. And then you also have concentration and memory issues. And then patients usually have sleepiness. So patients can have either one of these symptoms or they can have a combination of these symptoms. So if we just look at acute fatigue, this is the easy one. This is where you, for instance, have an infection like influenza. Patients will come and complain about fatigue. It's easy identifiable and easy treatable. So the causes for subacute or chronic fatigue, this is where it gets a bit more complicated, and this is probably where we see most of our patients. And the easiest way to think about this is to divide it into specific systems. So first of all, if you look at your cardiopulmonary conditions, that's usually things like heart failure, COPD, and sleep apnea. And we'll get back to sleep apnea a bit later. Then you also have your metabolic or endocrinological conditions. The common things are thyroid problems, either hypo or hyperthyroidism, your chronic renal diseases, hepatic diseases, in adrenal insufficiencies, and we'll get back to that one a bit later as well. And then also your electrolyte abnormalities, hypernatremia, and then also hypercalcemia. If you look at your hematological or neoplastic conditions, that's anemia or occult malignancies. Certain infections can do it, infective mononucleosis, viral hepatitis, HIV, TB, those are the common ones that we see. And then you also have to think about endocarditis. Your rheumatological conditions are usually fibromyalgia and polymyalgia rheumatica. And we'll get back to fibromyalgia in a bit, because we have to distinguish it between chronic fatigue syndrome. Then your psychological conditions, that's depression, anxiety disorders, and then also your somatizing disorders. And then the last one is your medications, either substance abuse or side effects of medications. So if we look at chronic fatigue, and this is fatigue where you have it for longer than 6 months, various studies have shown that about 2/3 of patients will can have these symptoms. And some of these cases, the main complaint is overwork. And this has been seen in the US, where the length of work week has been getting longer and longer. In a small majority of cases, this presenting symptoms of chronic fatigue can be explained by chronic fatigue syndrome. And the distinguishing thing there is that there must be strong evidence of neurological dysfunction. So patients who don't meet the criteria for chronic fatigue syndrome, or they don't have any other explanation for symptoms, we would then classify it as idiopathic chronic fatigue. It's important to know that these are both exclusion criteria. And another thing will be for us to distinguish between chronic fatigue syndrome and also fibromyalgia. So if we look at the diagnostic criteria for the from the International Organization of Medicine, it's a very specific criteria. And first of all, you need to have all three of the following symptoms. So it says that you need to have a substantial reduction or impairment in your ability to engage in pre-illness levels of either occupational, educational, social, or personal activities that persist for, once again, as we said, more than 6 months, and is accompanied by fatigue, which is often so profound that it is it's either new, so it hasn't been there for life, and it's a result of an ongoing excessive exertion and is not substantially alleviated by rest. So it's a lot of things in one sentence. So the other thing that you need to have is you need to have post-exertional malaise. That is worsening of the patient's symptoms and function after exposure to either physical or a cognitive stressor that was normally tolerated before the disease. And then the third important thing is patients need to have an unrefreshing sleep. So they need to have all three of those criteria, and then at least one of the following conditions. It's either need to be cognitive impairment, or they need to have orthostatic intolerance. So that's usually where you have symptoms that get worse when patients get in an upright posture, and it usually improves by laying down or elevating their feet. So the question is then, what is the difference between chronic fatigue and fibromyalgia? Because we confuse the two quite often. So the diagnostic features for fibromyalgia is first of all in the history. So patients usually have widespread multiple pain sites. It's usually there for more than 3 months. Patients are usually fatigued, they've got sleep disturbances, and then they can have other symptoms as well, like cognitive disturbances, headaches, and then also an irritable bowel. The physical examination, the important thing there is they've got widespread tenderness, and it's usually on the 9 sites, and we'll get back to that. And the other important thing is there's no joint swelling or inflammation. Laboratory testing, very usually non-specific. Normal ESR, CRP, normal full blood count, and the other tests are usually normal. So what would be the differential diagnosis then for fibromyalgia? And what we look at are your rheumatoid arthritis or lupus, your polymyalgia rheumatica, but that's usually in elder patients. patients with myositis, where you will get an elevated muscle enzymes, and then also hypothyroidism and hyperparathyroidism, as well as your neuropathies. So, as we said, this is the sites where patients will need to have tenderness, and they need to have at least 6 or more of those sites that needs to be tended to diagnose it as fibromyalgia. So there are actually quite a few similarities between fibromyalgia and then also chronic fatigue syndrome. So as we said, usually females population, it's usually between the ages of 20 to 50 years of age. And then the symptoms can actually quite overlap: exhaustion, post-exertional malaise. They can have widespread myalgia, cognitive disturbances, sleep abnormalities, mood disturbances. As we said, the physical and lab examinations are usually unremarkable. And then there's usually associated disorder, for instance, a viral infection. COVID, we've seen quite a lot, stress, and then also your small fiber neuropathies. So when we look at a patient who's got chronic fatigue, we need to get a comprehensive history, a good examination, your basic lab test. An important thing is to update your cancer screening. And then another thing is to further evaluate the patient based on the absence or the presence of localized findings. So in our initial evaluation and history, it's quite important to ask open-ended questions. Things like, describe your fatigue. What do you mean by fatigue? Because different people have different interpretations of fatigue. And then also the pattern of fatigue. So the onset, was it gradual? Did it erupt? Was it abruptly there? Is it related to an illness? What is the cause of the fatigue? Is it stable? Is it getting worse? Is it getting better? Is there a daily pattern to it? The other thing is to ask, what makes it better or worse? What is the impact that the fatigue has on your daily life, like work, socializing, things that you used to do before? And then also how your loved ones and people closest are reacting to your symptoms. So there's a couple of survey instruments that you can find online for screening. And so basically, the first one is you can do a brief fatigue inventory. And this is basically where the patient fills in a couple of questions where they answer yes or no. This idea of if the patient has fatigue. Then the two things that's actually quite important that I ask my patients is the short patient questionnaire. And this is to see if a patient has symptoms of depression. And depending on the score, they will get a probability of major depression or any other depressive. And the other one is also for anxiety, to make sure that your patient doesn't have any features of anxiety. Based on a score, it will give you a index of suspicion if a patient has anxiety or not. So from your history as well, patients usually with underlying medical conditions often associate fatigue. They are for activities that they are unable to complete. So by contrast, the patients who have psychological medication or toxicities, they are usually tired all the time. Their fatigue is usually not associated, related to the exertion, and it usually does not improve with rest. And as we said, it's important to look for substances, especially alcohol and other stimulants, domestic violence. And then a very important thing is to look for your other conditions like depression, anxiety, So from your history as well, it's quite important to find out about the patient's quality of sleep. And we will get to obstructive sleep apnea in a second as well. The other important thing is to get a complete list of medications, and that is over-the-counter medications as well as prescribed medication. The one that I usually see in my practice the most is beta blockers. Lots of patients are on beta blockers, and beta blockers are known for giving you fatigue. They also look at your other medications like your benzodiazepines, antidepressants, your first generation antihistamines, and then also your GABA analogs. Also important, social history, and find out about stresses at home and at work. So just to get back to sleep apnea, we actually see it quite a lot, and the clinical features for sleep apnea is what we all know. So usually if you've got an increased neck circumference, if you've got a narrow epiglottis, and then the common symptoms are patients, do they wake up in the morning feeling tired? Do they have a headache? There's a whole list of things, and it's always important to ask about these symptoms to get an idea of if a patient has sleep apnea. You also have the stop bang questionnaire, where a patient will answer yes and no, and it will give you a scoring criteria of if the patient is low risk for obstructive sleep apnea or high risk. And most of my patients I send for sleep studies as well, and you'll be surprised how many patients actually have obstructive sleep apnea and how their fatigue improves after getting a CPAP machine. The physical examination, it's important here to look for specific causes for fatigue. And once again, a good general examination will help you quite a lot. Look at the general appearance of the patient. Is there evidence of thyroid disease and cardiovascular, also your neuromuscular examination. So a good examination will rule out a lot of your things. So lab tests basically start off with the common things: your full blood count, your electrolytes, glucose, kidney function, renal function, TSH. Then also, if you suspect a patient might have a myositis or myopathy, to do a CK. Hepatitis C and HIV if you have the risk factors. It's important to avoid unnecessary testing. So especially in the beginning, unless you've got a very good clinical suspicion. So the important thing here is everything comes at a price: extensive laboratory and a radiological evaluation. In the absence of a history that points to something is of little value. So in a study that they've done in 100 patients where the chief complaint was fatigue for at least 1 month, they could only clarify about 5% of cases what the underlying cause is. So it's not really going to influence your that much. Another important thing to always look at is chronic adrenal insufficiency. And I think we probably get confronted with it a lot more than we think, but we're not completely fully aware of that. And what are the symptoms? The most common symptoms are usually weakness, fatigue, patients get easy tired. They've got loss of weight, they've got gastrointestinal symptoms. And as you can see, nausea, vomiting, it's varies from 75, 86%, which is actually quite a lot. The signs are usually weight loss, 100%, hyperpigmentation, 94, although you have to look very carefully for it. And then also your hypertension with systolic blood pressures of less than 110. Your most common laboratory abnormalities will be hyponatremia, hyperkalemia. So always be aware of that and think about chronic adrenal insufficiency. And we all know the clinical and lab findings for adrenal crisis. And this is patients who come in dehydrated, hypotensive, they've got shock that's out of proportion with their current illness. If they've got a history of nausea and vomiting, weight loss, anorexia, abdominal pain, unexplained hypoglycemia, unexplained fever, and then your electrolyte abnormalities. Once again, if you look at this list, a lot of these patients that come into EC or come into your general practice can present with these symptoms. So if you look at cancer screening, it's important to look at the patient's age and sex and look specifically for occult malignancies. For example, if a patient is about 45 years, to do a colon cancer screen, and if it's normal, then it's not necessary to do it within the next 10 years. They suggest that every patient that's over 55 years of age with a back history of more than 30 years needs to have a CT scan done. And then your females should be screened for breast cancer if they haven't been screened in the last 2 years. So if we look at the diagnosis, first of all, if you have localized findings, you will target on that. If a patient has a murmur, you will do an echo. If a patient doesn't have any localized findings, if you can't find anything, you will reassess the patient in 1 to 3 months' time, and you would repeat your basic bloods. So if you think a patient has chronic fatigue syndrome, and it meets the criteria, and it has been there for more than 6 months, it's post-exertional, and they've got sleep apnea, sleep or cognitive issues, it's most likely chronic fatigue syndrome. So other additional testing, they don't recommend that you look for infections, especially cytomegalovirus, Lyme's disease, Epstein-Barr. Shouldn't test for immunological deficiencies, your inflammatory diseases, vitamin deficiencies, or even celiac disease. That is, unless a patient has specific symptoms that will guide you towards that. They do not recommend that you do any radiological imaging like CT scans in the absence of any specific disease. And this is all guidelines by the CDC, as well as the International Chronic Fatigue Syndrome Study. So the management, it's important to treat the underlying cause. If you've got idiopathic fatigue, usually the treatment for that is antidepressants, and you would use something like the SSRI, and that specifically for your depressive symptoms. They do not recommend that you use any stimulants for these patients. And then also you need to do cognitive behavioral therapy as well as exercise therapy. The important thing here is to follow the patients up regularly, have a multidisciplinary team like a psychologist and a psychiatrist to help you with this, and physiotherapy and occupational therapy also plays a big part in this. So the prognosis is usually not very favorable for both conditions. So for idiopathic fatigue, it is actually better than patients that has chronic fatigue syndrome. And observational studies have shown that these patients have a higher risk for suicide than the general population, except for patients with chronic fatigue syndrome. And I think it's probably due to the fact that patients are just feeling unwell the whole time. Thank you very much.
Yeah, thanks, Cornel. I look like I tick all the spots on the scale for fatigue. Look, I always say it's a topic that, you need to have a ball of steel actually to present with confidence, because the truth that everybody is really complaining of fatigue. The question that how do you actually define it scientifically? And I think you have done it quite very well in that aspect, that we actually know, because majority of patients that came to our ECs, most of them is fatigue, and most of them really, I think, underlying depression. And during COVID, that's what we get to know as a long COVID, which of course doesn't make sense. But I think it's just like And I think sometimes for us, I think if you probably have to put the scale, so every emergency physician, doctor, they will tell you how much fatigue they are actually, but I think because of the accumulation of night calls and everything. But some probably, again, not everybody will have exactly the same symptom. Some people might have underlying process that happening, So sometimes very important actually to look underneath to actually investigate the patient to, for the common things, just as a part of medical preview checkup. And I think probably the age of the person matters quite a lot, how old they are. I mean, if a young person probably could think that maybe just overwork, lack of sleep and others, but if somebody above age of 50, or if they're female, you'll be concerned about, you have to think about anemia, you think about, anemia, you think about probably above age of 40 males, you obviously think about working, depression, and yeah, so I think for me it's a good presentation, Cornel. I love it.
And as I said, it's probably easy to ram off a couple of examinations, but I think a good history, good examination will guide you in what direction to go. And then, as I said, the things that I specifically focus on with my patients is sleep apnea, and we pick actually that up quite more often than we think. And then the other one is to always think about your adrenal insufficiency. That's now except the other ones like your thyroid, your common causes of fatigue.
I think sleep apnea, let's go back there, because I mean, when I'm tired, my wife say I always know. So do I need a CPAP machine?
Well, the stop bang questionnaire can guide you there because it's a scoring system. And it will define it as either low, intermediate, or high risk. And if you were to put yourself in that questionnaire, you probably wouldn't be high risk, and probably wouldn't need.
No, and it's also, I mean, a lot of patients, I've always asked the wife, and the wife will always tell you that after drinking wine or something, the patient snores, which is, but it's also the rest of the symptom. I think it's chronic. So, and it's the things like, do you wake up feeling tired in the morning? Do you have headaches? Do you have to go for an afternoon nap? Having an afternoon nap on a Saturday and Sunday is not bad, but if you need to have it during the week, the whole symptom profile.
Hypertensive, neck circumference, all of that.
Let's go back. I think Leanne mentioned a very important point here. Stop bang. How long does it take to actually assess a patient quickly for sleep apnea, for especially if you're in EC, you're exhausted, you're having patients that are coming having this fatigue, you get pissed off because your concern is like, I mean, really? Yeah, I'm having more people trauma. How many minutes?
It takes like 2 minutes because so they ask you, are you snoring? Yes or no? Are you tired? Yes or no? Is it observed? Yes or no? Are you being treated for high blood pressure? Do you have a BMI more than 35? Are you older than 50? Do you have a neck size of more than 16 inches? I think that's about 42 centimeters. Yeah. If you're male or female, and then it will put you based on those questions.
Yeah, but there's something very important about the stop bang for guys out there. There are very few questions that are very subjective, and some few questions that obviously require the partner. And then there are a few questions that require the physician. So sometimes you might not get your score fully, especially if the patient is not married. So are you snoring? That fall out, obviously.
Once again, if you've got an index of suspicion, it's good to either admit the patient for a sleep study or you do it as an outpatient.
Yeah, so the moral of the story that don't assume someone's chronic fatigue is malingering. I think look underneath and see how you actually can assist the patient actually. And I think for me, it's really a very important thing. And I really have an issue with fatigue. I think for me, mine probably lack of sleep. I don't know, but the question that mine get better when I run, obviously. So I think it's very important that you must take time just to do a proper history on your patient and look at those holistic tests. Yes, you might not be able to do everything in EC, but eyeball the patient and see which are the patients that you need to refer to the physician to have a proper workup because they're not really an acute process, or which one you need to admit to that you're concerned about malignancy or treatable condition immediately. So you need to be able to read about your patients and then see, because you just can't turn them away. And obviously, if they're young, as I say, the approach will be different compared when they're older people, like elderly people. And then,
So
Quite a lot.
Yeah.
People on
Yes.
any questions, guys? Come on, let's discuss this topic. It's getting exciting.
just regarding the thing about sleep apnea, I had a patient. Well, so I asked him specifically about sleep apnea, and his wife was there, and he said, and I asked him what work he does. He actually works for a company that provides CPAP machines. So, and I said, but have you ever tested yourself? He said, no. He doesn't think he's got sleep apnea. So I admitted him for a workup, and I said, the only reason why I admit you is because I'll do a sleep study while you're in hospital. And he actually turned out to have sleep apnea and got a CPAP machine, and actually symptoms improved. So you have to specifically look for him. This was funny because he actually supplies CPAP machines.
So now he must start by himself. Okay, guys, come. Any questions? Hello.
We'll be able to do
Any comments on this chat? Do you have any comments? And let's see whether they have any comments there. And let's see. Any other question, guys? Come on. In the chat. Let's look at the chat.
Is the to overcome the Eastern perspective. The coach of Leon Strong, this semi-final has been a massive opportunity for his side. The most important thing is the progress. If we can just go on the field and take a step in the right direction, I think we've been doing it.
Sorry, the mic is on the loudspeaker. Can you kind of repeat your question? I can't hear you because it's having a lot of echo on it.
Coaches and players.
Okay, please your question.
The Captain Park kicks off at 3 in the afternoon. In some cricket news, the Proteas will be able to learn from their mistakes as they shift their focus to Zimbabwe. That's in the T20 International Tri-Series in Harare. Yesterday, the Black Caps of New Zealand beat South Africa by 21 runs at the Harare Sports Club. New Zealand posted a competitive 173.5 in that.
Yeah.
Okay.
All right. Okay.
If
And-
there's no
Any more questions? That there are quite few comments here. Maybe you can run through them, all of us, guys. Recording has stopped. No, not yet. Recording has been okay. All right. Any other questions? So in this case, I would like to say thank you guys for attendance, and I think it's been amazing having about 70 people attending. It's been amazing. Thank you so much. Join us next week. Wednesday, we have a presentation, and then on Thursday, every week we have that, and the link remains the same. Thank you, guys, and do have a blessed day today. Dr. Godinho?
Thank you so much. Bye-bye.
Thank you.